kind of crazy that we've gone 4 or 5 years and not talked about kidney stones at this point, because it is one of the more common things that we all deal with. But we're really excited to have our good friend, Dr. Jonathan Katz, on here.
This is the Man Up Podcast, a doctor's guide to men's health.
If you've been enjoying listening to our podcast, please hit the subscribe button on YouTube, Spotify, and Apple Podcasts.
My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. This week's episode is titled Rock Hard Problems, the painful truth about kidney stones. My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. Justin, we have, I may call him a legend, but, a great friend of ours who's going to be joining us today to talk about kidney stones. And man, this is, we take calls, so we deal with this a lot. But hey, at the end of the day, it's one of the things that most people out there fear about ever getting.
Yeah, it's kind of crazy that we've gone like 4 or 5 years and not talked about kidney stones at this point, because it is one of the more common things that we all deal with. But we're really excited to have our good friend, Dr. Jonathan Katz, on here. Dr. Katz, please introduce yourself to our listeners.
Thank you so much, guys. Let me just say it's an honor and privilege to be here with you both. I'm an endourologist who specializes in treating kidney stones at University of Miami. And I will also just make a short plug for my lab. We have an automation and surgery lab. We're actually trying to automate ureteroscopy with laser lithotripsy, the most common surgical procedure for kidney stones.
That's sick.
So Dr. Katz is trying to put Justin and I out of a job.
That's the dream.
Maybe we should reconsider having him on this pod.
He's truly one of the thought leaders in the space. He's a leader. He has his own lab for kidney stones. So we brought in a big time guy, good friend of ours who trained with us at U Miami. So we're going to talk mostly about general stone stuff, this one, and medical management and dietary lifestyle. We'll have Dr. Katz back on to talk about surgery at another time. But let's get into it. So, John, or Dr. Katz, how common are kidney stones? It seems like, at least in Florida, everyone gets them.
Can I go by gatos for the rest of the...
Yeah, so we can go by gatos.
Excellent. Kidney stones are very common. Probably more common in the southern United States because it's hotter, people sweat more and are more dehydrated. Roughly 10% of the U.S. population is affected.
Damn. So that's a lot. What about men versus women? Is there a difference there?
Historically, it was more men than women, but I think that's been trending towards equivalence.
Okay. All right. So you touched on it. So you're talking about the South, dehydration. Like, come on, tell the listeners, what really causes a kidney stone to...
So the way I think about it is there are really two main factors. And if you think about it, minerals or crystals crystallize out depending on what the constituents of that fluid are. And then if you add fluid, they do not crystallize out as much. They get reabsorbed by the fluid. So you have two factors at play. You want to dilute whatever metabolic abnormality might be driving your stones. So that's where drinking a lot of water comes in. But then there are all these metabolic abnormalities you can have, especially diet mediated, but some people are just born with them. That can cause kidney stones. A third thing I'll just throw in there that I love and have a slight obsession with that I can't find how to use clinically is urinary stasis. So when urine just sits around, it definitely predisposes you to kidney stones. So that's where a lot of patients get bladder stones because the urine sits around in the bladder. But also kidney stones, they more commonly affect the lower pole. So the kidney has sort of an upper pole and a lower pole, and maybe people call it an interpole. But the stones primarily form in the lower pole or most commonly. And I think that has a lot to do with there's just more urinary stasis because it's got to go up to get it down the ureter as opposed from the upper and interpole.
Fascinating. So there's a lot of different things that could be causing stones. And one thing that we always see from our patients, though, is they come in and they're like, I have a stone. You see it on a CAT scan or you see it. They come into the ER and they're like, when did this happen? Did this just happen yesterday? How long does it typically take for a kidney stone to form?
So I guess I would take a step back and say probably the most common kidney stone is calcium oxalate, which makes up about 80 to 85% of the stones in the U.S. And those probably take a long time to form. But there are other rare stone types that can really form quite quickly that are sort of the exceptions. But certainly infections or abnormal urinary pHs, like the acid base, can drive some of those rarer stones to form rapidly.
But what about those calcium stones? Like how
I think
long
they
would
take
it take?
years in general. If it's your first time hearing about a stone and you're in your 30s or 40s, it probably took years to develop. I think. I
Now,
don't know that there's like a great
is there? I
evidence
don't know.
body
I'm
of
asking you.
evidence.
You're the stone
Yeah.
guy.
No, I tell patients, for example, when they have their first stone at, let's say, 70, I frequently tell them, I'll see you again in 70 years. Like that. There's no need probably to really focus on prevention. Whereas frequently in the younger patients, I'll be much more active with focusing on prevention because I think some of those stones take a really long time to form. But obviously, if they start to become recurrent stone formers and have a second event, then I definitely pay attention and work on prevention.
Now, you touched on it. You kind of mentioned, you're like, hey, most prevalent stone, most common stone is calcium oxalate. But for our listeners here, break it down. What are all the different types of stones that you can make, like composition wise?
Sure. I don't know that I can hit every single type because there are a lot of rare ones. But primarily, I think about them as they're calcium-based stones. So those are calcium oxalate and calcium phosphate. There's uric acid, which is another sort of big chunk within the minority. There's infection stones. There's cystine stones, which are a very rare sort of genetic condition. And those are going to be your most common types of stone.
And now, of those stones, you mentioned some genetic components. So can I have like a family history that's, going to make me more inclined to kidney stones, or is there a genetic component that can be passed down that makes me more likely to develop kidney stones?
Absolutely. I think kidney stones run rampant in my family, which is probably part of the reason why I went into this. My grandmother had stones, my dad had stones, my sister had stones. I'm just waiting for mine. I mean, I get dehydrated every day in the operating room. And so, it's only a matter of time. Hopefully my autonomous ureteroscopic system will be ready by then. No, if one immediate family member has had a kidney stone, it probably increases the likelihood by about double. So you go probably from 10% to 20%. But the more family members you have, I think the more important it is. And I think I actually tried to do some research in this space of sort of dietary changes for people interested in prevention just based on family members alone. It would really like sort of flip the paradigm to prevention instead of treating after you form a stone. But it's pretty hard to convince anyone to spend the money on doing a 24-hour urine test, which is how we check what metabolic abnormalities you might have, and also committing to lifelong dietary changes based on the findings. But I do think, in the interest of focusing on prevention instead of after you have the worst pain of your life, there is some logic to doing that.
So I've had some patients come in, and they'll come in and they'll be like, hey, look, yeah, my dad just gets a ton of kidney stones, been recurrent. Guy's like 30 years old. So he's like, hey, I want you to screen me for kidney stones. Is that such a thing or no?
To my knowledge, there's no evidence to do it, but I think it's not crazy to do an ultrasound. The problem is now if you find a stone, are you really going to treat it? If you've never, I like for patients to have experienced stone pain before I operate on them, because I find that the surgeries can cause some significant pain. And if you've never suffered from a stone and you're like, this doctor is the worst, he put me through this terrible thing. It's like, oh.
No, it's fair, but you so you think it is though somewhat reasonable if someone comes in, they have a family history, and they're like, "Hey, listen, I am worried. My dad had stones, my mom had stones, my sister had stones."
Yeah,
like in your situation, to get a
sorry, I didn't mean to get. I think
I'm
a
just saying,
renal
you're right.
ultrasound in that setting feels like, what's the downside? There's no radiation exposure. So the biggest downside is just an incidental finding that didn't need to be found. But, like the world has moved towards like these executive health screenings with, I don't know the full body of literature around that, but I bet it's pretty thin. But there's a logic to it, right? I mean, if you find something early, you could really nip the problem in the bud. Maybe you get some overtreatment, but if you can afford it, then I think it's reasonable to offer.
I think that makes a lot of sense. I think
without any evidence behind what I'm saying.
No, I think it makes sense just from a logical perspective. The risk to the patient in terms of radiation or anything like that with a simple ultrasound is zero. So I think it's totally reasonable. Now, we've been talking about stones. Now we talked a little bit about family history, but In your mind, what is the single biggest lifestyle mistake that people are doing that puts them at higher risk for kidney stones?
Okay. I think of kidney stones in general as a disease of obesity and metabolic syndrome.
Interesting.
That's certainly not always the case. I mean, we certainly have skinny patients with stones, but they're not the majority. And therefore, I think it's pretty obvious that diet and lifestyle make a big difference. Now, I don't think they've ever actually shown that exercise can prevent stones in patients who have formed stones. But to me, I just look at our patient population. And in general, the ones who are skinny with stones have pretty obvious metabolic problems. When you check a 24-hour urine, it's pretty likely a genetic, there's not much that could have been done and are probably the minority of our patients. So just to underscore, healthy diet and exercise, even though, again, there's not a ton of literature to support it, because think about how you would do that study even. It would be pretty challenging. As opposed to, I know everyone wants to hear hydration, but I won't do it. I won't do it.
Well, that's funny
what I was going to argue. Yeah, I think both Kevin and
maybe we're just some general urologists to you, John, but we go hydration is the biggest problem.
Yeah,
I think
thought you were going to say
the problem with that, to me, or at least part of the problem, is it's very easy to blame the patient in that space and say, oh, you're just not drinking enough water. But the reality is drinking 3 liters of water is very challenging. And a lot of people really don't like it. And obviously, most recently, I think it was in a New England Journal. No, it was in
that paper. What are your thoughts on that?
I love it. No.
So give our listeners
just to summarize,
a summary of it.
Basically, they randomized patients to really high intensity increased hydration training. I can't remember exactly what they used to try to reward patients for increasing their hydration versus, standard of care, tell patient drink more water and move on, and standard stone prevention. And basically they found no advantage in their sort of extreme encouragement arm of their study. And so the conclusion is very debated. So what does that show us? The problem is, in both groups, you had barely any difference in hydration. So the reality is it's very hard to convince people to drink more water than they're able to drink on their own. So what does that really tell us? Does increasing hydration not work? Probably it does work. It's just very difficult to get people to move the needle on that problem.
Yeah, I mean, No, I agree with you. I mean, so your point is, let's address things that are more addressable, I guess.
Diet and exercise is going to help your whole lifestyle, whole healthcare, lifespan, whatever buzzword we have here. You're just going to feel better and live longer. And if you have a kidney stone and I'm wrong because really you should have been increasing your hydration, I'll live with that. I just think it's definitely the case that diet and exercise and is going to help you.
But what about then? So metabolic syndrome, what about testosterone? Is low testosterone a risk factor for kidney stones?
We've looked at that. They definitely track. But again, I think there's so much noise there that, it's the same kind of problems are going to exacerbate both. Metabolic syndrome is going to cause. So what's driving?
So it's not necessary, but I think there's some data suggesting there is a signal for it as an independent risk factor of stone development. Is that correct? It's controversial. I'm not saying it's a fact, but
I'm going to say I'd have to circle back on that. I know I'm implicated in some publication on this subject.
I know you're on some publications, man. That's why I'm asking.
I feel like I'm getting called out here. But
I Dr. Katz is trying to blank that from his memory.
Can't remember which way the signal went. Because you would think men historically have more kidney stones, so maybe testosterone is problematic, right? But I can't remember what we found.
Dr. Dubin, do you remember?
Yeah, no, I think there was an association with low testosterone with some potential increased risk of kidney stone formation. I think there was a lower testosterone with higher risk of kidney stone development. I think Dr.
Wait, so then if you fix them with testosterone therapy,
I don't know. That's a great question. Does replacing your testosterone if you have low testosterone fix the problem? I would argue if you fix your metabolic syndrome, probably, based off of what Dr. Katz is saying. I think that
and I just want to be clear, I don't think that's at all everyone's problem, and just broadly speaking, I think that would help.
Yeah, I think that's reasonable, right? I mean, most of the things that your eating impact a lot of things. And it's just amazing how people don't think about lifestyle when it comes to stones. They think about their, everything else about their lives. But when it comes to stone formation, which is potentially the most painful thing anyone will ever experience, eating healthy for a lot of people, exercising and losing weight is really going to make a difference in their lives.
Agreed. I couldn't help myself. I pulled up the paper on the subject that I was involved in, and there was no effect.
There was no effect.
Once you controlled for everything.
Okay, so there was no effect on yours. There was some paper, I think, that did have some data, but you can find a paper on
Again, I think exactly. It's a very messy space because there are a lot of factors that affect both, and so how to tease it all apart. Your idea of giving people low testosterone back testosterone, see if it prevents their stones, is one approach to actually do it. And maybe there's some evidence that that's reasonable.
I think
all right, Dr. Katz, gym culture. All right. So, guys are down in protein shakes, hitting the creatine. The stack is very important to, us guys in the men's health space. So, are any of these supplements or any of these things we're drinking a problem or to causing kidney stones, or is this all myth?
I think some of the protein supplements I tell patients to dial back on, specifically animal-based protein powders are definitely more of a problem. So, we commonly tell patients dairy, milk, yogurt, cheese, that's all fine. But plant-based protein is much healthier, and non-dairy animal protein should be minimized. So that's the number one dietary recommendation, that when I say, I feel patients conveniently try to misunderstand what I'm telling them. They don't, no, I just have fish. It's like, that's not what I just said. But, and then after the fact, when the 24-hour urine comes back and shows no sign of change with just dietary changes, then we go back through it a little more carefully. It's like, no, I thought you said chicken was fine.
So it's all animal. It's not just
all
red
non-dairy animal protein. In fact, fish is the worst.
Oh, wow.
Yeah.
So
it always takes people by surprise. Chicken
pescatarian?
is slightly better. What's that?
So sorry, continue your thought.
Oh, chicken is slightly better than the rest, but I'm not 100% sure. I think it's the purine load. It's just more dense in fish. But there's also, I was reading, it's just the specific amino acids I think are a lot more sulfur based, which are more of an acid load also. So it's a multifactorial thing.
What about creatine? Does that
Totally
have any impact?
fine. I don't
Totally
think it
fine,
has
right?
any impact.
So,
I've looked into this because I get asked that, and I'm always like, let me check open evidence real fast.
yeah, no, I think it's interesting because you're right. I think changing this idea, it's not just red meat. I think a lot of people think red meat when they think especially uric acid.
Yes, 100%.
And so it's all meat other than the dairy protein. So, and then the so you, like, if you're having kidney stones, but you want to get your protein, and you can go to
the
protein,
exactly. But I think that's more expensive. Obviously, I'm not hitting the gym as hard as some of my friends,
but no, it's an important factor for certain people, right? That's a small change that they can do where they can get their protein source and reduce their risk for stone formation. But this leads to our next one, which a lot of people are consuming a lot of: energy drinks, and then also sodas. We know that there's definitely a signal for sodas that can cause kidney stone formation, but what about energy drinks as well?
I'm not a fan of energy drinks. I think there's a lot of artificial additives that I don't feel are good overall. Their exact role in kidney stones I never get too into because I think they're just unhealthy. Coffee and tea are surprisingly fine, even though green tea maybe has oxalates, which we haven't really discussed. But I think even green tea has been shown to be helpful for preventing stones. But coffee's natural, or, I guess we can all debate what natural means, but it's a pretty, it's been out there for a long time. And, and my favorite is it prevents dementia and seems to be pretty well tolerated by humans. So
these are all energy drinks you're talking about. I know you're talking about in general, like additives and stuff, but like, what about Celsius?
So what's in Celsius exactly? I mean, there's sugar,
I don't know.
for sure, right? There's definitely added sugar.
They advertise themselves as like the natural energy drink though,
I guess, I don't mean to get political, but there's a part of me that really loved the Make America Healthy Again movement, at least in terms of additives and natural foods. Now, I think they go off the deep end when it comes to vaccines, but, to me, it just makes no sense to have something that's obviously a whole bunch of synthetic molecules that no one's really lived with, tested, and they don't necessarily feel right. Like when diet soda, I'll drink it, but I don't feel like I'm doing my body a favor. It's like I love the
tastes so
taste of the
good.
And it
diet
tastes so
Coke,
good and 0 calories.
but then I'm also like, I find I have to pee a lot more. Like I really have the overactive bladder in response to diet soda, which is, common. But yeah. Like I think, would I let my child have this? And the answer is absolutely not. So then
That's fair. I mean, but what about soda in general for kidney stones?
yeah,
Like,
definitely
there are
bad.
good sodas.
There's a lot of evidence that soda's bad for kidney stone formers. High fructose corn syrup is specifically bad. I think there's something about the phosphoric acid in the colas that's not good.
Wait, is there any data on like sparkling water? Yeah, I drink
I've never seen
sparkling.
I drink a ton of sparkling water. I think that's
Yeah, okay.
totally fine. I've looked into it a few times and never found anything, so I felt reassured. There's stuff about the teeth. I don't think it's great for the teeth, but I don't think
Right.
kidney stones are a problem.
Well, but what about? But isn't one kind of soda, like dark sodas, are bad? Like you can
I think
have.
that's the cola situation.
Right.
But I think I don't think Sprite is the answer. People will tell you lemon, lime, lemonade even. There's some benefit because you're getting that citrate, and citrate we haven't really touched on, but is a stone inhibitor. But I think there are a lot of easy ways to get lemon and lime that don't involve all the synthetic.
Let's stick with that topic. All right. Patient comes in. All right, I know there's still a lot of stuff we got to cover. Patients always come in. They're like, hey, there's this family herbal like recipe. Usually includes like some turmeric or some sort of lemon or something like that.
Chaga Are we not going to talk about Chaga Piedra? In Miami, that's I say 50% of my patients take it.
And so does it work? Not work?
There's some evidence for it. I always thought, in the back of my mind, if urology doesn't work out, maybe I'll make my own herbal remedy brand. Dr. Katz's tea.
Huge.
Yeah. And I think Chaga Piedra, I would definitely put in it.
So you think that there's something there?
There's even some data. There's a randomized trial where they showed, I think after shockwave, more fragments pass when you're on Chaga Piedra. Just the number of patients I have who say their stone is broken is pretty remarkable. Again, it's hard to really study these things because they're expensive trials, and who's funding the Chaga Piedra trial?
No one who is already making money from it. Yeah.
I don't think it's amazing, right? Like I think it's not really moving the needle for most patients, but I always tell them, go for it. No problem. Why not? It's a tea.
Now, back to foods for a second, because we highlighted some beverages. We highlighted loosely, dairy good, other meats bad in general if you're a recurring stone former. What are some other?
I wouldn't limit it to that, but sure.
What?
You said you were like limiting who it's good for not to eat.
It's good for it's bad for
animal protein.
Yeah. Sorry. You're right. I'm sorry. But usually I think we are biased, right? Because most people come in, they've already had a stone and they're asking us for the diet. That's why I went that route. But you're right. This is general habits for reducing any risk of stone. But what other foods should people avoid if they're worried about forming stones?
I guess salt is the big one missing here. Salt in and of itself is not necessarily harmful. It's just that when you take excess salt, because your body really tightly maintains a certain level of sodium in your bloodstream, which is how your brain basically works, it's going to dump the salt in your urine, which is great, except it brings calcium into your urine. And that calcium finds oxalate or the different phosphate stones and crystallizes out and causes stones. So one of the big changes we make is lowering salt. And, salt can get you in all kinds of ways. If you go out to restaurants, they add salt to everything. I think Pura Vida, not to shame Pura Vida, but I don't know if you guys saw this article in the Post about, when they opened in New York, they had to post their sodium content.
Yeah.
And it was like 10 times the recommended.
It was crazy. It was crazy.
And Pura Vida is like supposed to be a healthy, that's like their vibe at least. But,
no, it's crazy. It was really bad. Their calories were through the roof. Their tuna melt, which I think they actually removed from their menu since that came out.
Oh, I love a tuna melt.
It was worse than like a Big Mac. I went to Sesame. I had a tuna melt this weekend. It was so good. They have a great tuna melt.
Well, I mean,
So-
dude, come on. At the end of the day, something that tastes like, you're like, man, this is healthy and it tastes so good. Like, come on, there's got to be a little bit
Doesn't
of a catch,
exist.
right?
I would say I always knew. I knew they were only
But you kept eating it. You kept eating it.
You do what makes your partner happy. I don't know.
Now you bring Now you bring up an important point about calcium and also vitamin D. I want to put in there too, because I think a lot of people supplement these things, and calcium has an important role in stone reduction as a supplement. But also vitamin D can be complicated because I think people are overdoing it on the vitamin D. So
Yeah.
can you just explain that dynamic there?
Sure. I think they both can cut both ways. You want to have a normal amount of calcium in your diet, and you want to keep your vitamin D in the normal range. Either can lead to excess calcium in your blood, which can then result in excess calcium in your urine. We recommend 400 milligrams per meal, or around 1,200 milligrams of calcium per day, to just maintain a normal calcium level. If you overdo it, like Tums famously has a lot of calcium in it, and people who are overdoing it that way can cause stones. So there is like an absorptive hypercalciuria that can happen. And then vitamin D, if you're overdosing on vitamin D, can also cause problems with calcium hemostasis. That's not the word, homeostasis. And yeah, I think both within the normal boundaries is healthy. And then when you overdo them or underdo them, they can both cause problems. Calcium is the most interesting because I think historically urologists did tell patients to lower their calcium intake, but that turned out to be incorrect. This was probably in the 90s. They did some work on this and found that actually a normal amount of calcium is good for you. And of course, the logic being oxalate is the big driver of calcium oxalate stones a lot of the time. And if you're reducing your calcium in your diet, the oxalate is unbound and then gets absorbed more easily. And so that drives up the oxalate part of the calcium oxalate stone. And so by having calcium at the same time, it binds the oxalate and you just poop it out instead of absorbing the oxalate. I explain that every clinic to people, and I'm not really sure I do a great job.
No, that makes
conveying it.
100% sense. That
Yeah.
made 100% sense. And with the vitamin D, I think a lot of people are obsessed with getting vitamin D. We're in Miami outside, and obviously I don't think you can overdose on that, but I think that goes to the dehydration aspect, probably being outside so much, trying to get your vitamin D that way. Is there an amount of vitamin D that's too much for you to orally consume? Do we know that threshold or no?
I don't know that threshold off the top of my head,
Okay.
but it's
But
definitely
overall,
out
like-
there. And
Yeah.
I would say you should do it monitored. So you should monitor your vitamin D level and make sure you're not overdoing it. And then if you're a stone former, just check what your urinary calcium is to make sure it's okay.
Yeah, because
I always
people are
tell
so
patients-
obsessed with it.
Yeah, it's true. But I just tell patients, look, your bone health is very important and like a big mediator of how you age. So if you need calcium or vitamin D, that's fine. We'll work around it to make sure it's not causing you kidney stones, because there are always ways to get urinary calcium down.
So actually, let me ask you this. We kind of assumed our listeners out there have an idea of like, what are some tests that we would do to kind of get an idea of, do we have some metabolic irregularities? So Dr. Katz, could you go over like, what are some of these simple tests that we can do to determine this?
Yeah, so usually I start with a little bit of blood work to check both the calcium level, some basic acid-base stuff, a vitamin D level, uric acid, because uric acid is obviously, we've been discussing, can form some stones, and then a 24-hour urine collection. 24-hour urine collection is pretty involved and requires some commitment from the patient to really collect their urine for a full 24 hours. And it's very finicky. Like if you under-collect or over-collect, it's going to really affect the results. I always underscore, please follow the directions carefully. And then in the 24-hour urine specifically, we look at all kinds of things, the total urinary volume to see if they're adequately hydrated. And again, I don't make it the biggest deal, but I do sort of encourage them, if they're on the really low end, that they got to do better. We look at urinary calcium, urinary oxalate, pH, urinary citrate, urinary uric acid, a whole bunch of different metabolites.
Maybe we should add a testosterone on there too.
Is
I'm
it
just
in the
trolling.
urine?
I'm just joking. No, not in the blood. Blood test.
Okay. I was like,
But just to highlight, Dr. Katz, he has helped us urologists out immensely with a nice website called Stone Prevent URS. I believe that's the website, right? Is that it?
Yeah, well, we call it stone preventers. Play
Okay.
on words with prevent URS and preventers. So
Uh,
yeah, trying to, in the era before large language models could just handle all 24-hour urines, um, it was nice to sort of help anyone go through the 24-hour urine and figure out the right, at least dietary and basic dietary medical management.
Yeah, no, I mean, but the nice thing here is what you described is really not that bad. I mean, you pee in a jug for 24 hours, but other than that, it's really, there's nothing invasive going on. It's a blood test, it's a urine sample, and then you might have a good idea of what things you can do. And a lot of the things that we have already discussed. But oftentimes before they see you for that, they come in because they had a stone or they passed a stone. And so one of the big questions I think that a lot of people don't understand is, especially for people who've never had a stone, what is the typical signs and symptoms of having a kidney stone? What should someone be? What's a sign like, oh man, I think I actually have a kidney stone?
To me, the real hallmark is, immediate or rapid onset severe flank pain. And flank pain, it's different. If you feel your bottom rib, just below that is what I think about as the standard place for it. And sometimes it's different for everyone. It could be a little more to the side or a little more to the front, but that's certainly its most classic. It's often associated with nausea and vomiting. I think, I'm not totally sure. It might just be the pain itself causing the nausea and vomiting. Occasionally, it could be sort of urine actually backing up and getting stretched, probably causes some nausea. Obviously, the left side's next to the stomach, but the intestines are close by in all these areas. So, nausea, vomiting, severe pain, flank pain, sometimes burning with urination, especially as the stone moves distally down the ureter. You can also have referred pain to the testicles or in men, obviously. And yeah, occasionally fever, chills, infection symptoms. And that's when you're really at the emergency stage, because then you really have to decompress the system. And it's one of the most rewarding procedures, I feel like, for on-call urology is when you put up a stent and you see the pus come down and you're like, wow, that really needed to get drained.
yeah, and that was, you probably, did real impactful work doing, putting that stent up because that bacteria could have gotten backed up and it would have been bad news,
Yeah, exactly.
Yeah. So I mean,
Wait,
go ahead, Gil.
No, I'm just going to pick Dr. Katz's brain because he kind of glossed over it real quickly. And I don't know, it kind of goes against I think a lot of grain of what a lot of urologists think. You just kind of go like, oh, the nausea and vomiting is not sometimes it's not directly related to back pressure of urine. I think a lot of urologists will kind of.
Yeah, I don't know. I think, obviously, forticell rupture, let's just say, that's basically when the kidney sort of springs a leak and some of the urine, and you would think that's obviously going to make the nausea and vomiting worse, but actually that tends to help with the pain. So I guess, it's also, so it's probably not mechanical irritation of urine, right? It's probably something having to do with the stretching of the collecting system that causes all that pain and probably nausea. But I think in and of itself, severe pain will just cause nausea, I think.
Yeah. And I think also we shouldn't underplay that, right? I think when we're talking about signs that you should go straight to the ER, you mentioned them, fevers, chills. You may see blood in your urine. That is not a sign necessarily to go to the ER. That can happen as well. But fevers, chills, I think uncontrollable pain, and uncontrollable nausea and vomiting. I mean, we've all stented people in an emergency situation because their pain is, even though it's a small stone, they have a high chance of doing it. Their pain is uncontrollable. They're nonstop vomiting. They look miserable. So these are real things that, although your kidney function may be okay, these other issues may be okay, it can be something that's going to push us to make the decision to go to the ER.
Yeah. And to that point, I am a big pusher of primary ureteroscopy. I think in the right patient, It really is a service to try to treat the stone and get it over with rather than just stent and come back another day. The temptation, there are a lot of reasons why we might be pushed to stent, even hospital systems. Oh, we don't have the laser rep, or they come up with all kinds of explanations sometimes. The reality is it's on call and it takes a lot of resource. The procedure goes from being 15 minutes to maybe an hour and 15 minutes. So it's a lot more resource intensive for on call, but I think it makes a big difference for our patients.
Now, a lot of, it's when people hear kidney stones, they've heard like, hey, I've heard kidney stones are worse than childbirth. So is that actually true, Dr. Katz?
Look, full disclosure, I've done neither. But I've had many patients say it's worse than childbirth. And I think part of it is also like childbirth is somewhat expected. It's coming, it's going to hurt, and you have a baby at the end of it, right? And there's like epidurals. There's all kinds of, there's a whole industry around breathing. Like no one is taught how to breathe through a kidney stone ahead of time, and it's certainly neck and neck for what's worse. There's Dornier. Dornier is a company that makes a lot of, at least urologic products. I'm sure they make other things, but they actually were trying to create a website, and it might still be live, Worst Pain Ever, like an informational site for patients with kidney stone. But that's how much it resonates. And they had, it makes sense to patients from what I understand.
I hope to never have that pain. Kevin, have you ever had a kidney stone?
No, I have not.
I mean,
No,
statistically
I will
speaking.
say I find the patient population to be less grateful than enlarged prostate patients. And I don't know what it is, but I think it might just be stents are so miserable to patients that they're never really that happy afterwards.
All right. We're
relieved
talking
to
about
have
it
this-
anyways. We're talking about it anyways.
Yeah.
Tell our listeners what a stent is. What is a
Okay.
stent, and why can it cause so much discomfort?
I tell patients, imagine I just rubbed your eye for a while, and then on top of that, I left something in your eye. You're probably not going to be happy.
Oh my God, that's what you tell people?
I think stents are really that bad. I looked at, when I was a fellow at Kaiser, we looked at ER visits within 30 days across urology. We were trying to build a prediction model to see who would actually get admitted and whether it was worth going to the ER and whether that could be predicted. The study was a total failure, but 20% of ureteroscopy patients were going to the emergency room within 30
I'm not
days,
surprised.
which is incredible. And I think a lot of it has to do with counseling. A lot of times patients tell me like, or like sometimes a patient will have seen multiple urologists and they'll tell me like, oh, the other urologist says just a ureteroscopy, nothing to worry about, no problems. And you're telling me it's going to be like terrible. There are all these risks. It's going to hurt, and, I don't know. I'm not sure. The other thing is narcotics, right? In our guidelines now, it says not to prescribe narcotics for ureteroscopy. And I'm not sure. There's some evidence, right, that it doesn't really help and narcotics can lead to addiction. But I think the pain can be quite severe afterwards also. And certainly we do routinely place stents, and there's a whole discussion around whether we should try harder not to stent patients. But I think the majority of urologists probably pretty routinely leave a stent afterwards. And there can be a lot of discomfort with them. Basically, sorry, I never described the stent. So a stent is, a tube that can be made out of lots of different sort of malleable materials that one coil is up in the kidney, and then it goes down the ureter, and a second coil to keep it in place in the bladder. And patients can have discomfort anywhere along the stent. Some patients have terrible bladder pain, some patients have terrible flank pain, and some patients have something in between, probably ureteral pain. And then every time they pee, the urine refluxes back up into their kidney, which is probably already inflamed and hurts more, and probably depends on the compliance of everyone's kidney. And if their kidney is like very compliant, maybe that hurts more. I don't know, or maybe that hurts less. The studies can certainly be done, but I think bottom line, we don't have a great solution. None of the medications really take all the edge off, but we have a lot of different medications we try.
I hate stents, man. Yeah. I mean, every time I look at a patient in the face, I'm always like, man, I'm sorry. I think we're going to have to leave a stent after this. It's a large stone. And I'm like, please don't hate me after this. Just please don't.
Well,
No,
I
I
think
mean, I think the point you mentioned is the important thing is counseling, right? I mean, I tell them that they're going to have irritation, they're going to have blood in their urine, they're going to feel like burning when they pee. Hopefully, if I'm keeping it in, it's on a string for 5 to 7 days max, and they're getting it out of there. And then, but the other patients who do truly need it, whether it's a massive stone that you need to come back at a later time or they're infected, I think a lot of those people, they do feel a significant relief from the previous stone pain, which in those situations, I think it's all situational, right? And setting expectations and setting realistic goals for what you're trying to do. Because I'm not saying it's the best feeling, but for a lot of times we just describe really painful stone pain for people who are brought to the ER because of it. And I think in comparison, it is most of the time more tolerable. I'm not saying it's a walk in the park, though.
I guess also do you guys ever check out kidney stones on Reddit? It's like a community that is so traumatized by stents. It is like
Really?
staggering. You feel like as a urologist looking through it, you really are left wondering like maybe this
Right.
isn't the correct way. And in the absence of an obvious ureteral injury, I think there's certainly relatively decent evidence that you don't need a stent. The problem is the 1 in 100 times where you don't leave a stent and then have to go back and stent a patient, it's traumatic for the urologist because it really feels like you obviously did the wrong thing. Whereas if you
Yeah.
put a stent in and it's a little patient discomfort and what's the big deal? You pull it out 5 to 7 days later. Well, the reality is some patients get urinary tract infections with the stent, and it's probably, if you don't need it, better, but it's hard to convince the urologist, I think. And I myself feel like I'm guilty of it. So it's not I'm not preaching. It's my own guilt, I suppose.
It's
All
hard.
right. Well,
It's hard.
yeah, look, it's a hard decision. And I think, the exact way that you portrayed it is the way that we're all thinking about, right? That 1 in 100, right? Those patients unfortunately weigh on us as surgeons, right? So look, we kind of went a little tangentially talking about surgery, which we're going to talk a whole episode about, kind of just to wrap some things up here. So do most kidney stones actually pass?
So I'm not sure the answer to that question. Certainly most ureteral stones, I think, broadly speaking, do end up passing because when you look, the ones that come to our attention as urologists are probably not in that bucket. But the emergency room, believe it or not, does handle a lot of kidney stones without calling us. And those all is the wrong word, but many of them probably end up passing. But I also think the true rate is not always well known because I don't think routinely outside of a urologist are people getting follow-up CT scans, which is sort of like the ground truth. And we don't know how many just sit there, maybe non-obstructive, and so the pain goes away and what happens. And, it's not uncommon that I see a patient who's had a stone for much longer than expected, sitting in their ureter. And in general, it's fine. But one does wonder if that predisposed people to scar tissue in the area or other problems with their kidney.
So someone comes in, I'm a patient, I go to the ER, I have kidney stone, and they go, "You're going to be fine. Your pain's okay. We're going to send you home." What can I do to help pass my kidney stone?
It's a tough one. So obviously, sorry, did you say a size there?
Just say it's like a smaller stone, say like a 3 to 4 millimeter
Yeah,
stone.
there's some evidence Flomax or alpha blockers can help. People have tried calcium channel blockers. Some people will say you should drink a lot of water, but to me, this was always like, I'm not totally sure on the mechanism there. You're trying to build up pressure, so won't that just cause more pain? So what are you really winning there? There was some data on roller coasters. I don't know where I saw it, but I thought I had read that sex helps, but then I could never find it again. So I'm not really
No,
sure.
I found that paper. I saw it.
No, but I went looking for it the other day because, I thought before I tell a patient that I should really make sure I have a source lined up and then I couldn't find one. So I don't know.
Yeah, but
Maybe
so
it
you're
was
saying it's
retracted.
hard. So are you saying some of it's luck? I mean, because it might
Definitely.
be, right?
Well, so, we looked into whether or not we could predict stone passage using convolutional neural networks like artificial intelligence to try to learn the features of the stone or the anatomy that would predict passage, and actually did predict pretty well which stones would not pass. That was a preliminary study. But there's some thinking that, the jaggedness of the stone, how much thickness in the ureter there is in that area, all these things could play small factors that do predict it. I don't think it's really well known right now what those exact parameters would be, but certainly one could imagine a smoother, softer stone is more likely to get pushed through, whereas a more jagged stone is less likely to get pushed through.
I
Right,
love how
'cause
we
those are
asked
all
you
ran-
to- This is amazing.
Those are all
just because-
random.
Yeah, go ahead.
Wait, those are all random, right? Like the whole
Yeah.
look, when I go in and I do surgery and I see someone was like, oh, this is a jagged stone. Oh, this stone was round. How is there
So
some
it's
determination for that?
You mean on the seat, like ahead of time?
Is there a
Or-
cat
No.
score for jaggedness of a stone or something?
the Dubin Katz jaggedness score, of course. There are certainly different stone types that are going to be more jagged than like uric acid, for example, is going to be the smoothest of the stone types, right? Pure uric acid stone is pretty smooth. Though that being said, a pure calcium oxalate monohydrate stone is pretty smooth. I think it's the calcium oxalate dihydrate that forms these like rougher crystals that are probably a little bit more jagged. Younger people tend to have more calcium oxalate dihydrate. But the other thing is, a lot of times when we send stones for chemical analysis, of course, we're only sending parts of the stone. You never know if it comes from the outside, which is where it matters if it's jagged, or the inside. It's not always the same. In fact, most stones are probably mixed composition. So it's likely more complicated.
But this is why we brought you on, because, I was expecting just an answer of medical expulsion therapy, but we got real
Jumping jacks.
like it, like Flomax, aggressive hydration, pain control, which I thought was like what we typically do. But you're right. Like we don't know how successful that will be for a lot of patients. And we don't know if that will make the difference at the end of the day. What our goal is to make sure that you're comfortable and you're able to go home and pass the stone as comfortable as you can is really what our goal is, without providing narcotics, obviously, which is part. I don't provide narcotics in that situation.
Ever?
I don't.
Wait, when
I
a
try
patient's
not-
in pain?
No, if they're in the hospital, I give them narcotics, but I don't like to send them home significantly with narcotics. I'll give them maybe like a tramadol or something like that, but like not like a narcotic. I try not to give them a narcotic.
I think tramadol is a narcotic.
Yeah, it's like a maybe a narcotic.
I mean, that's what I say. I think it's an opioid.
Yeah, I don't know. I just don't like the idea of like, I try to stay away from opioids.
That's so funny. I know it's certainly in fashion, right? Like a decade's worth of publications against narcotics. I just think, I guess when I was in college, I took a class called Psychology of Pain. And I just remember this PhD in pain psychology research going on and on about how doctors do not understand pain and they have no empathy. And I always think about that in the back of my head. And I try to remember, I had one surgery. I had kidney stone. I had wisdom teeth removed. And I took Percocet and it made the pain go away.
Yeah.
I slept on the couch and watched a movie or two, and the whole day is a haze. And then I never took it again, and I'm grateful that my OMFS surgeon who did it was old school and prescribed narcotics for me,
There's a time and a place for every medication. To say that narcotics don't have a role in medicine is crazy, of course. But,
I do think the days of like 30 pills for like a ureteroscopy is probably excessive, but like maybe 5 tablets to just carry you through a couple days if the pain is really bad isn't the craziest thing, something in between. That's all.
I think that's fair. Go ahead, Kev.
All right, we're gonna wrap up here. There's actually a question. We keep talking about stones that are blocking, stones that are not blocking. So a lot of patients will be told, maybe not necessarily by a urologist, but incidentally found that they've got this stone that's just hanging out in the kidney, and it's not causing any pain, not blocking. So do you need to do anything about this? And, is it going to cause problems, right? That's always a question that comes next. Like, when's it going to cause an issue?
So one thing you'll hear me say all day in clinic is I don't have a crystal ball. I can't tell you for sure. But I tell patients probably for a single, let's say sub-centimeter stone, there's about a 10% chance every year or something like over 5 years, maybe 50%, that it grows or causes infections or pain and causes us to need to do something about it. And whether they have one kidney, a solitary kidney or two kidneys, I tell them the same thing, right? And so the problem with the solitary kidney scenario is, well, now it's an emergency if it causes something. Those patients tend to prefer me to do something sooner. But I try to dig back. These days, the electronic health record keeps things for a long time. So I'll find an old CT sometimes. And if I can see it's been the same for 5 years, my enthusiasm to do anything about it is much diminished. But I take them all as they come and try to explain the risks and benefits and let the patient decide.
I think that's fair, because you're right. I think a lot of us tend to say, listen, less is more, right? I think a lot of people don't want to get a surgery. They don't want to have an intervention, especially if it's not indicated, and especially if it may not bother them at the end of the day or ever bother them. Now, the final question I really have is, we've talked a lot about stones, but I feel like a lot of people, despite having stones, don't see a urologist unless they require surgery. So, when is it an appropriate time if I'm worried about kidney stones or have a history of kidney stones? When is it an appropriate time to see a urologist about kidney stones?
You're saying without even a diagnosis of
Well,
kidney
either
stones?
way, like if I'm a
Yeah.
human being and
I
I'm
think
interested to talk about, I want to learn about kidney stones or like, I mean, it doesn't have to be right away. I don't think someone, unless it's a family history, you're going to answer the question prior to having a kidney stone. But if I'm someone who either had a kidney stone or is concerned about getting a new kidney stone, when is an appropriate time to see a urologist?
so. I would just say that probably there's a shortage of urologists. So we probably don't have the capacity to see everyone who's just curious about kidney stones, right? Or, I mean, there are going to be practices that can handle that volume, but, to me, that would feel a little overwhelming, probably on top of all the patients in need who are desperate for stone surgery because they have a stent placed 2 months ago and are living with the stent. We're also now seeing people who are just curious about stones. That being said, I'd be happy to talk to anyone about kidney stones in general. To me, I think starting with a primary care doctor in that scenario makes a lot of sense. They could go through the sort of nutritional recommendations with them. Once they already have a stone, I'd say some common sense is reasonable. A patient who has, a less than 5-year life expectancy, let's just say, who's incidentally found to have a stone hanging out in the kidney, maybe it's in the lower pole, probably doesn't need an urgent referral to a urologist. But I see those patients all the time. And certainly if they've never passed a stone before. Now, once you start to be a recurrent stone former, I think it's always worth a visit with either a urologist or a nephrologist, someone who's going to review a 24-hour urine collection with you and work on prevention.
Yeah, I think that makes sense because I think one thing that we've learned is just like a lot of things in medicine, and we talk about men's health all the time here. Um, the more we learn about lifestyle, whether it's diet and exercise, the more we learn about things that we can prevent. And I don't think that people have a good idea. And I really am grateful that you came on, and especially highlighted metabolic syndrome, that those kind of things can really impact your kidney stones and or lack thereof, or the increased risk of them. And, we think about our erections, we think about our testosterone levels, we think about our fertility, but guess what? Lifestyle is a huge factor in kidney stones. And obviously, we're going to have you come back on and talk about surgical interventions because there's a whole bunch, and you're leading the field in new interventions, including these AI technologies that you're coming up with. But, just as a final note for, this aspect of stone management, stone risk, and recurrence, any final thoughts or comments to our listeners today?
I would just highlight really the basics: live healthy, diet, exercise, and I believe limiting non-dairy animal protein is better for your health
Overall.
Remind
me, are you a vegetarian?
Plant-based.
Are you
I
plant-based?
always say I'm a non-observant vegan.
Because I'm pretty sure last time at your house we had chicken, and I think we had some beef products.
Non-observant.
Yeah. No, but I think there's something to be said about it for sure. I don't know, Kevin, any thoughts?
No, all this conversation just brought me back to residency. for our listeners, we all did residency together, and just remembering Katz talking about how, like, yeah, I'm plant-based, and then one day during lunch, bad lunch, man, the bro was just going at it. All the animal protein.
Look,
Hey, listen,
we should all aspire to our best selves.
I think hey, that's fair. That's fair. That's fair. That's fair. All right, Dr. Katz, any final you want to where can they find you? At University of Miami, right? And you want to give the lab a
University
shout
of
out again?
Miami. Automation and Surgery Lab, JonathanKatz.me.
Great.
Let's
I mean,
connect.
this was awesome. Thank you, Dr. Katz, for coming on. We're gonna have you on again to talk surgery. Long time overdue for our listeners. Thanks for listening. As always, download, subscribe, give us a review, 5 stars. You can find us on YouTube. Subscribe there. We've finally hit over 1,000 subscribers there. Let's make it 5,000 soon, and keep going to the moon there. For Kevin and Justin, thanks for listening. Until next time, have a good one.